You know, we all have this craving for the magic bullet in medicine.
Oh, absolutely.
We see a headline about some breakthrough drug or a new treatment for, I don't know, Alzheimer's, and we just want to believe the problem is solved.
Just give us the pill.
Just give us the pill.
Right.
But when you actually, open the hood and look at the clinical data, man, it is rarely that clean.
It's almost never clean.
Yeah.
And in psychiatry specifically, we are constantly navigating a minefield of trade-offs.
Mm-hmm.
You get these so-called miracle drugs that might, in reality, barely move the needle statistically, or treatments that work for reasons completely different than what the marketing says.
And that is exactly where we are going today. We're taking a stack of research from the February 2026 issue of the Carlett Report. Psychiatry, which for you, the listener, is kind of the gold standard for unbiased, no pharma funding analysis.
And we are going to separate the hype from the clinical reality.
Yeah.
We've got a lot to cover. We're looking at a major antipsychotic that tried to expand its territory into PTSD, and, well, it failed. Hard. We're also breaking down the terrifying calculus of medication during pregnancy.
And then there's this surprising data on surface dogs that really challenges what recovery even looks like.
It's a mix of some heavy science and some really surprising psychological twists.
So let's get into it. We are starting with Brexpiprazole, better known by its brand name, Rexulti.
Right. So this is what we call a third-generation antipsychotic.
Okay, which
Yeah.
implies there were 2 generations before it. And I assume those were the real sledgehammer drugs.
Exactly. The first-gen drugs, they just blocked dopamine receptors completely. Very effective, but lots of side effects.
Right.
Second gen was a bit more refined. This third generation, which also includes drugs like Abilify and Vraylar, is designed to be a partial agonist.
So instead of a sledgehammer, it's more like a gentle nudge to the dopamine system.
That's a great way to put it. Yes, a gentle nudge.
And it's been a pharmaceutical darling lately, hasn't it? It's already approved for schizophrenia and depression.
It is.
But the big story here is that they tried to get it approved for PTSD, post-traumatic stress disorder.
Yeah.
They ran the massive trials, spent the millions, and the FDA came back with a hard no.
Which is pretty rare. You know, usually by the time a company submits to the FDA, they're pretty confident they've got it.
So what went wrong?
Well, the FDA looked at their 2 trials and found some glaring issues. Only one of the trials was actually positive.
Only one.
And even that one had what we call a withdrawal confound.
I read about this, and it seemed like a massive oversight. Can you walk us through it?
Sure. So to get into the trial, patients had to have PTSD. But many of these people were already taking antidepressants or other meds to manage their symptoms.
Okay.
And the study design required them to stop those medications.
They had to wash out everything. That sounds like a recipe for disaster.
It is.
You're taking unstable patients and just pulling the rug out from under them.
And it creates a huge variable. So one group stops their old meds and gets the new drug, Brexpiprazole.
And the other group?
The other group stops their old meds and gets a placebo.
Oh, I see where this is going. If you take someone off their meds, they're going to crash. They're going into withdrawal.
Bingo. The placebo group got significantly worse. And it was likely because they were suffering from withdrawal, rebound anxiety, insomnia, mood instability.
And since Brexpiprazole works on similar pathways, it basically just treated the withdrawal.
Precisely. It masked the crash. So the drug looked effective by comparison, but it wasn't necessarily treating the underlying trauma of PTSD.
It was just preventing the withdrawal syndrome.
Yes, from the drugs they'd just stopped taking.
Wow. That is such a subtle but critical distinction. It's a false signal.
It is, and the FDA caught it. And on top of all that, the study was so exclusionary.
How so?
Dr. Mark Zimmerman estimated only about 5% of real-world PTSD patients would have even qualified for the trial.
5%. So even if it had worked, it wouldn't apply to the vast majority of people walking into a clinic. So for PTSD, Brexpiprazole is a bust. But, and here's the pivot, it did manage to snag an approval back in May 2023 for something else.
Right, for agitation associated with dementia in Alzheimer's.
And this is a huge area of unmet need. Agitation, I mean, the yelling, the aggression, the restlessness, that's often the breaking point for families.
It is. It's what forces families to move a loved one into a nursing home.
It's just heartbreaking. So having a pill for this sounds like a godsend, but looking at the data, that godsend label might be a bit of a stretch.
The FDA was skeptical here, too. They actually asked for a third study because the data was so borderline.
But they eventually approved it.
They did. But we have to talk about the difference between statistical significance and clinical significance.
This is a concept we come back to a lot. Just because the math says it works doesn't mean the patient actually feels better.
Exactly. So they measured this using something called the Cohen-Mansfield Agitation Inventory. Just picture a scale that rates agitation behaviors, and it goes all the way up to 174 points.
That's a lot of room for improvement.
A lot. And to see a change that actually, changes a family's life.
Where grandma stops screaming or maybe starts sleeping through the night.
Right. For that, researchers generally say you need the score to drop by about 17 points.
Okay, so 17 points is the target for a life-changing difference. What did Brexpiprazole achieve?
5.
5. That's barely a blip.
It's a blip. Mathematically, it wasn't 0.
Oh.
But practically, it's debatable whether a caregiver would even notice.
And you have to weigh that tiny benefit against the risks, because giving antipsychotics to the elderly isn't exactly like, giving them a multivitamin.
Far from it. All antipsychotics carry a black box warning for elderly patients with dementia.
Because they increase the risk of death.
They do. In these trials, the mortality rate in the drug group was 0.9% versus 0.3% in the placebo group.
So it effectively tripled the death risk.
Now, the absolute numbers are low, less than 1%, but it's a real signal.
So the takeaway isn't never use it.
No, but you manage your expectations. It's a tool with a very small benefit and a very real risk. And it just reinforces that non-pharmacologic interventions, like changing the environment, behavioral therapy, are still the first line of defense.
It's a classic case of treat the patient, not just the chart. You have to weigh the human cost. And honestly, nowhere is that balancing act more terrifying than when you're treating 2 patients at once.
You mean pregnancy?
Exactly. The report has this interview with Dr. Amritha Bhat on perinatal mental health, and it just completely reframes how we should think about this. The old school thought was just stop everything to be safe.
Which Dr. Bhat points out is a dangerous oversimplification. The question isn't, is this medication safe?
Right.
The real question is, what is the risk of the medication versus the risk of the untreated illness?
Because untreated depression or anxiety creates its own kind of biological toxicity for the baby. Right?
Absolutely. Untreated depression affects the baby's development, it increases the risk of preterm birth, and critically, it puts the mother's life at risk. Suicide's a real concern.
And Dr. Bhat notes that stopping antidepressants during pregnancy roughly doubles the risk of relapse.
Doubles it, so you're rolling the dice.
But let's address the fear. Every parent worries about birth defects. What's the verdict on SSRIs, the common ones like Zoloft or Prozac?
The consensus now is pretty reassuring. The early studies that suggested a link to autism have been effectively refuted by better, larger studies.
So no association.
No association. That's a massive relief for a lot of people.
I'm sure.
There's a risk of something called poor neonatal adaptation syndrome. About 25% of babies exposed might be, jittery, have some muscle tone issues, maybe trouble feeding for a few days.
Which is stressful for a new parent, but it passes.
It's self-limited. It goes away.
Yeah.
And compared to the risk of a mother in a severe depressive episode, most clinicians view it as a manageable trade-off.
Okay, so if a woman needs to stay on her meds, is there a best one to use?
Dr. Bhat mentions sertraline, which is Zoloft, is often preferred because very little of it passes into breast milk. But the golden rule here is this. The safest medication is the one that actually works for that patient.
Don't switch to a safer drug that just leaves the mom depressed.
That defeats the entire purpose. Minimizing the number of exposures is the goal.
Okay, now, for postpartum depression specifically, there's a new player on the board. A drug called zuranolone. This is completely different from a standard antidepressant, isn't it?
Totally different mechanism. It's a neurosteroid. It mimics a hormone called allopregnanolone.
Which crashes right after birth, if I remember correctly.
Exactly. Hormone levels just plummet after delivery, and for some women, that crash triggers the depression. Zuranolone essentially cushions that fall.
And it works fast.
Incredibly fast. Within days. And it's only a 14-day course.
That is unheard of in psychiatry. Usually we're telling people, give it 6 weeks to kick in.
I know, but there's a catch with how you take it.
Which is?
You have to take it with a high-fat meal. And we aren't talking a spoonful of peanut butter here.
It needs serious fat for absorption.
Significant fat.
Cheeseburger therapy.
I mean, I can't officially prescribe a double quarter pounder, but pharmacologically speaking, yeah, that's exactly what the doctor ordered.
I can see the marketing campaign for that now. But seriously, it's a Schedule 4 drug, so there must be a sedation risk.
Yes, a big one. You should not drive after taking it. It can really knock you out. It's ideal for women with a history of hormonal sensitivity like PMDD who need that rapid stabilization.
Before we move on, we have to touch on postpartum psychosis. This is the stuff of nightmares, but it's so critical to spot.
It is a true psychiatric emergency. It is rare, maybe 1 or 2 in 1,000 births, but the stakes are life and death.
The risks are staggering.
They are. There is a 4% risk of infanticide and a 5% risk of suicide.
And it doesn't just look like standard depression.
No, it waxes and wanes. A woman might be totally lucid 1 minute and then delusional or confused the next. It almost looks more like delirium.
Wow.
And crucially, the treatment isn't just meds, it's sleep.
Sleep as a medical intervention.
Dr. Bhat says you have to prioritize sleep, even if that means stopping breastfeeding at night so a partner can take over with a bottle.
That seems like vital advice.
In this context, sleep deprivation is like throwing gasoline on a fire. The bottle is literally a safety device.
Okay, I want to shift gears to our research roundup. We found a study in this report that really blew my mind. It's about service dogs for veterans with PTSD.
Yeah, this is a study by Layton and colleagues and involved canines for warriors.
These are highly trained dogs, right?
Very. 60-plus hours of instruction. They learn tasks like blocking, so creating space in a crowd, or covering the veteran's back.
And the headline results were great. PTSD scores went way down.
A significant drop, yeah. On the CIPS-5 scale, scores dropped by about 7 points, and people stuck with the program. Dropout rates were way lower than with therapy or meds.
People love the dogs.
They do.
Okay.
And here's the twist. It's a really paradoxical one.
No.
The veterans reported feeling less lonely. They had more companionship. But when the researchers measured their actual social activity...
How often they went out, engaged with the world.
Exactly. That actually went down.
Wait, that is a huge paradox. They feel less lonely, but they're actually more physically isolated.
It forces us to rethink what recovery even looks like. We assume recovery means reintegrating, going to parties, being in crowds.
But for these veterans, the dog might be acting as a kind of shield.
It could be. A security blanket that keeps them comfortable, but maybe also keeps them stuck.
Or what about stigma?
That's the other theory, the stigma magnet. You walk into a grocery store with a German Shepherd and a vest, and suddenly you aren't just a guy buying milk, you're the veteran with PTSD.
People stare, they ask questions.
It makes a quick trip to the store a whole ordeal.
Yeah.
So the dog provides comfort, but it might also raise a barrier to the outside world.
So if the goal is feeling better, the dogs win. But if the goal is functioning socially, that data gets murky.
Which brings us to the ultimate mind game, the placebo effect.
Which we usually just dismiss. Oh, it's just the placebo.
We shouldn't. A new meta-analysis of 90 trials suggests we're leaving a lot of money on the table by ignoring it. The effect sizes are staggering.
Give us the numbers.
To put it in perspective for you, in statistics, an effect size of 0.8 is considered large.
Okay.
We're seeing numbers like 1.40 for depression and 1.23 for anxiety.
Whoa. So the placebo isn't just a trick of the mind. Statistically, it's packing a heavier punch than some actual treatment.
It's a short term, yeah. The takeaway isn't to give sugar pills, obviously, but we should harness that power, that early hope, that therapeutic alliance you build.
Yeah.
That is a massive part of healing.
Use the momentum. I like that. Okay, 2 more quick hits before we wrap. Vitamin D.
Yes.
Everyone takes it, but does it actually do anything for mental health?
The verdict is yes, but the dose really matters. You can't just take a drop here and there. The improvement peaked at around 8,000 IUs per day.
8,000. That's way higher than the standard recommendation.
It is, so you'd want to monitor your levels. But what's interesting is, while it helped depression, it had zero effect on anxiety.
So if you're anxious, save your money.
Or at least look elsewhere. And finally, a practical tip for weight gain. Antipsychotics like olanzapine. They're notorious for this.
I've seen patients gain 20, 30 pounds in a month. It's brutal.
It is. And the new guideline is simple. Don't wait for it to happen.
Be proactive.
Start metformin immediately, day 1.
Metformin is a diabetes drug, but we're using it preventatively.
Yes. It helps regulate metabolism. If you start it on day 1, you save an average of 3 to 4 kilograms of weight gain.
That's nearly 10 pounds you don't have to lose later.
Exactly. It's proactive medicine.
So pulling all this together, what's the thread here? We've talked about a drug that failed because it was just treating withdrawal, the complex safety of pregnancy meds, service dogs making you feel better while keeping you on the couch.
The thread is nuance. I mean, mental health treatment is becoming incredibly precise, But it demands that we look past the headline. We can't just ask, does it work?
We have to ask, how does it work? Who does it work for? And what are we actually measuring?
Exactly. Like with Brexpiprazole, a 5-point drop in agitation might be statistically real. But does it give a family their life back? Probably not.
Or with the service dogs, feeling less isolated is a huge win, even if you aren't at a party every night.
It's about defining what better means for the individual sitting in front of you.
Yeah, so here's a question for you, the listener, to chew on as you go about your day. We saw with the veterans that they felt better but did less. In mental health, does feeling better always mean functioning better? And which one should we actually be targeting?
That is the million-dollar question.
Yeah.
Sometimes comfort and growth are at odds.
Something to think about. Thanks for diving in with us today.
Until next time.